My approach to seeing a patient who may have a condition that we would identify as a mental illness, so depression, anxiety being most common in general practice, is to take a sort of a whole person approach to that. They have their own skill sets, they have their own strengths and resiliences as well, and exactly how they manage their distress is not going to be the same as somebody else. The goal at a high level is to make sure that the right medicine is used for the right person at the right time. And that may mean not using medications in some settings. Within the first consultation, the things that I would do is firstly to try to get the story, basically to understand the person, why they came in. So it's not a consultation I would normally want to rush. With the management of depression, we know that the thing that we really should be doing most, especially for mild, moderate spectrum depression, is psychological therapy, counselling, CBT, psychoeducation. And that talking about of what is depression, what the expectations are, what happens to people, that is psychoeducation. The focus, I think, really should be not turning to pharmacotherapy straight up. Certainly there's a role for them, but the evidence would suggest that psychological therapies, so some specific manualised therapies like CBT have quite a lot of quite good evidence, but interpersonal therapy, more psychodynamic-based supportive therapies, they've got reasonably good evidence in primary care as well. Those sort of approaches, I think, are really first line. And the important thing then is follow-up. It's coming back, well, what did you do? How did it work? Getting people to learn from the activities they've done. So there is no such thing as failure. Failure just means if you tried something, if you learned something about yourself. Part of the structured follow-up I would be to ask about how did you go with the medication? Normalising the non-adherence. So if someone took it for a while then stopped, well, why was that the case and why did that happen? And often there are very good reasons. Well, certainly very good reasons, and reasons that would make sense to the individual who's been asked to take the medications. And so trying to make sure that my patients feel comfortable having those discussions with me and with my colleagues if I'm not here, to me is a very important part of making sure that the right person gets the right medication for the right length of time. At the end of the day, consumers and their carers provide almost all the healthcare for themselves. Obviously I know a lot about medications, I know a lot about the diseases, I see a lot of individuals, but they're experts in themselves, so how the treatments are working for them, they're the people who are going to be able to tell me.